Welcome back to The Deep Dive. We're the show that digs into the latest research, pulling out those key insights just for you, our listeners.
Great to be here.
Today, we're tackling a really common and often tricky clinical challenge, managing thrombocytopenia.
Mm-hmm.
We all know the struggle, right? Whether it's patients with chronic liver disease facing procedures or those battling immune thrombocytopenia, ITP.
Absolutely.
Those really low platelet counts.
Okay.
They force some tough decisions. We're talking treatment delays, maybe even cancellations, and of course that higher risk of bleeding. It's a high-stakes situation.
It really is. And that's kind of where Avatrombopag, or AVA as we'll call it, comes into the picture.
Okay.
It's one of the newer oral TPO-RAs, the thrombopoietin receptor agonists.
Right, the TPO-RAs.
Exactly. And what they do is, well, quite clever actually. They basically stimulate the bone marrow to make more platelets. It's like nudging the body's own system along.
A nudge, I like that.
Yeah, and AVA being an oral drug adds that convenience factor, which can be a real game changer for managing patients long term.
So for this deep dive, our mission really is to step outside the very controlled world of clinical trials.
Mm-hmm.
We want to explore what the real-world data says about AVA. How does it actually perform, out in the wild with all the complexities of day-to-day patient care?
Exactly. What happens when it hits the clinic floor?
Right. We'll look into its effectiveness, the safety side of things, and crucially, how it's practically used, especially in some of those tougher patient groups, like people with chemo-induced thrombocytopenia, CIT, or ITP, even severe aplastic anemia.
Seeing how it fits into the real messy picture of clinical practice.
Precisely, how it integrates into the nuances and, let's be honest, the often unpredictable reality of managing these patients. Okay, so let's start unpacking this. Can you give us a snapshot of the studies we're drawing from for this deep dive? What kind of evidence are we looking at?
Sure. So we've gathered quite a diverse collection of real-world investigations. And like you said, these aren't your standard randomized controlled trials, your RCTs.
Which are great, but different.
Exactly. They have their place for proving efficacy in a controlled way. What we're looking at here are things like retrospective analyses, multi-center observational cohorts, even some really detailed case series.
Okay, so a real mix.
The real mix. And that's important because it captures a much broader, more you could say diverse range of clinical experiences. It helps paint a fuller picture, a more authentic one, of how AVA performs when it's really tested in day-to-day care.
It complements the RCT data.
Precisely. It fills in the gaps.
And what about the scale? Are we talking small studies, large ones?
Well, that's another interesting part. The scale and diversity are quite impressive. We've got everything from small focused case series, like there's one by Galamaga from 2025, just 6 patients with CIT. Very specific.
Okay, 6 patients.
Yeah, and then 2 individual case reports from ITO, which, despite being just single patients, give it incredible detail.
Sometimes those N-of-1 studies are really insightful.
They really are. But then we also have much larger cohorts. For example, Pascual-Izquierdo in 2024 looked at 268 adult ITP patients in Spain. That's substantial.
Definitely.
In between, there's Al-Samkari from 2021, a multi-center study with 44 patients. Wang 2024 looked at 94 pediatric patients, which is notable.
Pediatrics, okay.
And Tian 2024 studied 121 adult ITP patients in China. And just to add another layer, we even looked at a big network meta-analysis by Liu in 2025.
A meta-analysis.
Yeah, pulling data from 14 different RCTs, covering over 1,400 patients in total. So it's this blend of detailed case studies and large cohort data that gives us a pretty robust view.
That's quite a foundation.
Yeah.
Now, what specific conditions or indications were covered?
Well, the main focus and where we have the most data is definitely immune thrombocytopenia, ITP, both in adults and kids.
Okay, ITP is key.
It is. But we also saw important findings for chemotherapy-induced thrombocytopenia, CIT, where, keeping platelet counts up is vital for cancer treatment.
Absolutely critical.
And even some data relating to severe aplastic anemia. What's also really useful is the global perspective.
Where did the studies come from?
All over, really. We have U.S. data from Al-Samkari, a lot of valuable research from China, Liu, Tian, Wang, and then that large Spanish cohort from Pascual-Izquierdo.
So, U.S., China, Spain.
Yeah, getting these different real-world contexts is key. It shows us how AVA is being used and viewed in different healthcare systems, different patient populations, helps understand its broad applicability.
That makes sense. Different systems, maybe different practices.
Yeah.
So, okay, that lays out the sources really well. Let's get practical. Why were patients actually starting AVA or switching to it in these real-world scenarios? It probably wasn't always the first drug they tried, right?
You hit the nail on the head. It was rarely the first choice, at least in the data we reviewed. A major reason, maybe the biggest one, was simply that prior therapies weren't working.
Prior treatment failure.
Exactly.
Yeah.
A big chunk of patients switched to AVA because other treatments, sometimes even other TPO-RAs like Avatrombopag or romiplastim, just weren't getting the job done.
Okay.
Al-Samkari's ITP study, for instance, found 32% switched because their previous TPO-RA wasn't effective enough. Tian's study in China also mentioned many patients hadn't responded well to L-Trombopag or Hetrombopag before they tried AVA.
So AVA was often a second or third line TPO-RA.
Often, yes. Even in that small Galamaga case series on CIT, AVA came in after both L-Trombopag and steroids had failed. It really highlights AVA's role as a viable option when other treatments haven't worked. Kind of a lifeline for some patients.
Okay, so ineffectiveness is a big one. If the drug isn't working, you need something else. Make sense? What else drove those switches?
Another key driver was adverse events from the prior therapies. Side effects.
Tolerability issues.
Precisely. Sometimes patients just couldn't tolerate the side effects of the other TPO-RAs. Al-Samkari's study showed this clearly, patients switching from romiplastim because of things like bad joint pain, arthralgia, or even serious issues like VTE, venous thromboembolism.
Oh, VTE. Yeah, that's serious.
Yeah, definitely. And others switched from L-Trombopag due to things like headaches, cataracts, or concerning changes in liver function tests.
The liver function is always a watch-out with some TPO-RAs.
Right. And these aren't just minor annoyances. They can make sticking with the treatment really difficult, or even impossible. It underscores why having different options is so critical. What works for one might be intolerable for another. AVA provides that flexibility.
It's not just about the platelet count, it's the whole patient experience. I get that. Were there other, maybe less clinical reasons why people switched?
Yes, and this one was actually quite surprising, or at least the magnitude was. Convenience.
Convenience? Really?
Really. In Al-Samkari's study, for over half the patients, 52% improved convenience was the main reason they switched to AVA.
Over half. Just for convenience.
Yep. Think about it. Avoiding weekly trips to the clinic for injections, which you need with romiplastim.
Right, the subcutaneous injections.
Or avoiding the strict dietary rules with L-Trombopag, having to time it carefully around meals, avoiding calcium, that sort of thing.
That can be a real hassle day to day.
It really can. Especially, as Ito's case reports pointed out, for elderly patients who might find frequent visits or complex dietary timing difficult. AVA, being an oral pill you can take with food, just simplifies things dramatically. It makes treatment more sustainable, improves quality of life. That ease of use is huge for long-term adherence.
And that's a massive point for patient-centered care. Makes total sense. And then you mentioned specific clinical situations where AVA seemed to offer a unique solution.
Yes, absolutely. Take CIT, chemotherapy-induced thrombocytopenia. The Galamaga case series showed AVA being used to manage those low platelets in cancer patients.
Right.
And the goal there wasn't just boosting platelets for the sake of it.
Right.
It was about enabling the patient's anti-cancer therapy to continue without needing to reduce the dose or pause treatment altogether.
Which is crucial for cancer outcomes. Dose intensity matters.
Hugely. Maintaining dose intensity is often directly linked to survival rates. Without something like AVA, these patients might face delays or reductions, potentially compromising their fight against the cancer. So in these high-stakes situations, AVA acts like a bridge, keeping treatment on track.
Okay, let's pivot to effectiveness then. You mentioned boosting platelet counts.
Mm-hmm.
How well did AVA actually do that in these real-world studies? What kind of responses did they see?
Well, the results were pretty consistently strong across the board. Looking at that large Spanish ITP cohort from Pascual Izquierdo, the numbers are impressive. Overall, 92.2% of patients hit a platelet count of 58/109 present or higher.
92%, that's high.
It is. And even for those starting really low, below that 50 mark, 90.1% still reach that target. And, that 50,000 threshold is often a key target for managing bleeding risk, allowing procedures. It's clinically meaningful.
Definitely moves them into a safer zone.
It does. And then Al-Samkari's study, focusing on those heavily pretreated ITP patients who'd already failed other TPO-RAs.
The tough cases.
Exactly. Even there, 93% achieved that platelet response of 58/109L, and a really remarkable 86% got a complete response, meaning 100 or 109L.
Wow, 86% complete response in refractory patients.
Yeah, and it didn't seem to matter much if they'd switched from romiplastim, 94% response, or L-Trombopag, 91% response. AVA worked well after both.
Okay. What about other studies?
Similar picture. Tian's study in Chinese adults with ITP found 83% got a response. O30 A109L, and 62% got a complete response. And in kids, Wang's study showed an overall response around 72-73% at 4 and 12 weeks. So pretty robust efficacy across different groups.
And what about the actual increase in platelets? How much did the counts go up?
That's also quite striking. In Al-Samkari's study, for those patients who switched specifically because their prior TPO-RA wasn't working,
Non-responders.
right, their median platelet count jumped from a pretty low 28 A109L on the old drug to 88 I109L on AVA. That's a big leap.
From 28 to 88, yeah, that's significant.
And across all patients in that study, the median count went from 45 up to 114 AVIN 109L. These aren't just small bumps, it's a substantial improvement, moving patients from high risk to much safer levels. Shows AVA's power to really kickstart platelet production.
Those are definitely significant increases, especially for patients who were struggling before. Okay, so it works. But how quickly does it work? Time to response is often critical, right? If you need to get someone ready for surgery or stop acute bleeding.
Speed is absolutely key in those situations, and the data here is quite compelling. Back to that Spanish ITP cohort, Pascual Izquierdo found patients starting below 50 to 109L reached that threshold in a median of just 13 days.
13 days median.
Yeah, and even faster for some nearly a third, 32.2%, hit that mark within the first 8 days.
Within 8 days, that's rapid.
It really is. It allows for much quicker clinical decision-making.
What about the other studies? Similar speed.
Pretty much. Tian's study in Chinese adults reported a median time to partial response of only 7 days.
7 days.
And complete response median was 21 days. Strikingly, 55% of their patients got above 50 A109L by day 8.
Again, hitting that target quickly.
Exactly. And in the pediatric data from Wang, median time to response was 9 days, complete response 13 days.
So consistently quick across populations.
Generally, yes. Though one study did note that while AVA seems faster than Avatrombopag in kids, that potency might also carry a slightly higher risk of platelet counts going too high if not monitored.
Oh, okay. A trade-off to watch. But overall, that speed is a major advantage for stabilizing patients fast.
Definitely. Avoids transfusions, avoids delays, safer pathways for patients.
Makes sense. Now, beyond just the platelet count itself, what about the bigger picture? Did using AVA impact the need for other medications, particularly steroids?
That's one of the really positive downstream effects we saw consistently. A significant reduction or even discontinuation of concomitant meds, especially corticosteroids.
Getting patients off steroids is always a huge goal.
Always. The long-term side effects are just so problematic. So Al-Samkari's ITP study found 57% of patients who were on other ITP meds, including 63% on chronic steroids, could stop them after switching to AVA.
Over half stopped their other meds. That's great.
It's a massive win for quality of life. Imagine getting off steroids after years.
Yeah, absolutely.
And the Spanish cohort, Pascual Izquierdo, showed AVA allowed steroid dose reduction or suspension in 80% of patients who started with low counts.
80%.
80%. Even other less common ITP meds like fostamatinib, IVAG, mycophenolate, they saw reductions in 20-30% of cases too.
So a broad impact on reducing overall treatment burden.
Very broad. Tian's study in China echoed this. 75% stopped at least one other med, and 79% successfully tapered off steroids. And in kids, Wang showed the need for concomitant meds dropped steadily over 48 months, from over 55% at baseline down to under 15%. Corticosteroids were the most common ones stopped.
So AVA allows simplification of the regimen, fewer pills, fewer side effects overall.
Exactly. A substantial reduction in treatment burden.
Okay, that's a major quality of life benefit. What about reducing the need for more acute interventions, like platelet transfusions or preventing procedure delays?
Yeah, another clear positive signal in the real-world data. In that CIT case series by Galamaga, the patients on AVA needed 0 platelet transfusions.
0 transfusions.
And because their counts stabilized, their cancer therapy continued without holds or dose cuts. Again, critical for oncology.
Right, and in the pediatric study.
Wang noted that bleeding events and the need for rescue therapy, those immediate interventions, dropped significantly over time in the kids on AVA. Better overall bleeding control.
Fewer emergencies, less anxiety for families.
Precisely. Safer clinical courses all around.
Okay, it's clear AVA is effective across different groups. But let's dig into some specifics. What about those really tough cases, the heavily pretreated patients who failed multiple therapies? How did AVA do there?
That's where the real-world evidence is particularly encouraging. These are patients, who've often been through the ringer with treatments.
Running out of options.
Exactly. Al-Samkari's study highlighted AVA was highly effective even in patients who'd had a median of 4 prior ITP therapies.
4 prior lines. Okay.
And Tian's study in China showed a similar thing. Patients had received a median of 5 prior meds before AVA.
5 lines. Even more refractory.
Right. And in the Spanish cohort, Pascual Izquierdo specifically looked at heavily pretreated patients, defined as or 4 prior lines, with low baseline counts who switched due to failure. They saw a 79% response rate.
79% response, and those who failed at least 4 previous treatments. That's impressive.
It really is. It positions AVA as a genuinely valuable option for those difficult refractory cases. Offers hope.
And what about the strategy of switching between TPO-RAs? If someone doesn't respond to Avatrombopag, can they still respond to AVA?
Yes, and this is a key finding. The data strongly supports switching between TPO-RAs. Al-Samkari found AVA worked well even after patients failed Avatrombopag or romiplastim.
Supports the idea they have slightly different mechanisms or interactions.
Exactly. Different molecular structures, potentially different interactions with the receptor. So failure on one doesn't predict failure on another. Tian's study really drove this home. Among patients who didn't respond to L-Trombopag or Hetrombopag, 86% responded when switched to AVA.
86% response after failing another TPO-RA.
Yeah. And even more interesting, for patients who'd switched more than once, say, failed ELT, switched to AVA, maybe then switched again, the overall response rate was still 88%.
Shows flexibility.
It does. And Otto's case reports, though small, even showed successful reswitching. A patient might initially fail one drug, switch, and then maybe later switch back successfully, perhaps due to preference or convenience.
So there's real scope for personalization here.
Absolutely.
Okay.
Lots of flexibility in sequencing these agents.
That's great for chronic conditions. Speaking of which, how long does the response to AVA typically last? Is it durable?
Durability is crucial, and the evidence looks pretty good there, too. Wang's pediatric study showed sustained response rates, 62.3% at 24 weeks, still 51.6% at 48 weeks.
Okay, holding up over a year.
Generally, yes. And Pascual Izquierdo noted that loss of response was uncommon, less than 10% in their large cohort.
So once you respond, you're likely to maintain it.
It seems that way for most patients. Provides stability, less need for constant changes or rescue therapy. That predictability is huge for patients living with ITP long-term.
Okay, effectiveness looks solid, rapid, and durable, even in tough cases. Let's switch gears to safety and tolerability, always a critical piece. What's the overall picture?
The overall picture is encouraging. Across these different studies, different populations, AVA was generally well tolerated.
Okay, generally well tolerated. What does that mean specifically?
It means most side effects or adverse events, AEs, were mild grade 1 or 2 on the CTC-AE scale, which is the standard grading system.
So not severe for the most part.
Right. And importantly, these AEs often resolve just by adjusting the dose or sometimes stopping the drug temporarily. Studies like Wang, Pascual Izquierdo, Galamaga all highlighted this manageability.
Okay, manageable profile.
And that network meta-analysis by Luciu actually gave AVA the best safety profile among the TPO-RAs based on SUCR ranking.
Best safety profile, what was the ranking?
It was 23.8%. Basically, a lower SUCR score suggests a better safety ranking compared to the others in that analysis. So favorable overall tolerability.
That's definitely reassuring. But with TPO-RAs, the big concern is always thromboembolic events, TEVs, blood clots. What do the real-world data show about that risk with AVA?
Right, TVs are always top of mind. We need to look closely at this. In the large Spanish IPP cohort, Pascual Izquierdo reported a TV rate of 4.5%.
4.5%. What kind of events were these?
It was 12 out of 268 patients. Included things like ischemic stroke, pulmonary embolism, heart attack, peripheral artery disease, even a chronic IVC thrombosis. So serious events.
Definitely serious. Were there patterns? Underlying risk factors?
Yes, and understanding the context is crucial. Al-Samkari's study had one patient develop portal vein thrombosis on AVA, but importantly, that patient had a complex history of multiple prior VTEs, even while on other TPO-RAs and anticoagulants.
So a high-risk patient to begin with.
Extremely high risk. And Pascual Izquierdo noted 2 patients with TVs had antiphospholipid syndrome, APS.
APS, a known thrombotic risk factor.
Exactly. It reinforces the caution needed when using any TPO-RA in patients with established clotting risks. And another key finding, 3 patients with TVs in that Spanish study had platelet counts over 400 A-anoninine-L.
Linking it potentially to thrombocytosis, a very high count.
It strongly suggests a link, which underscores how important it is to monitor counts carefully and adjust the dose to keep patients in a safe range, avoiding those excessively high levels.
Right. Which leads us to thrombocytosis itself. You said high platelet counts might be linked to TVs. Was thrombocytosis common with AVA?
It was actually the most frequently reported adverse event overall.
Most frequent AE. How common?
The rates varied. Pascual-Izquierdo saw it in about 15%, 14.9% of their adult ITP patients. But in Wang's pediatric study, it was much more frequent. 46.8% of children experienced it at some point.
Nearly half the kids. Why such a difference?
Well, the pediatric study linked it to a few things. Higher AVA doses, having an upper respiratory infection at the time, needing rescue therapy, maybe combination therapy effects.
Okay.
And interestingly, kids who are newly diagnosed or had chronic ITP, and importantly, those who hadn't used a TPO-RA before, were more likely to get thrombocytosis.
This is maybe more sensitive to the drug's effect initially.
That seems to be the implication. It suggests AVA might be more potent than some others, leading to this overshoot in platelet production if you're not careful, especially in TPO-naive patients or kids.
Higher potency needing careful management. How did they manage it?
The consistent recommendation was dose adjustment or temporary suspension of AVA, and most patients in both the adult and pediatric studies could restart after the dose was adjusted. Manageable, but needs vigilance.
Okay, vigilant monitoring is key, especially in kids or new starts. Now, what about liver issues? Liver enzyme elevation or hepatotoxicity? That's a concern with some other TPO-RAs. Did AVA show a similar signal?
This is actually a really positive point for AVA. Al-Samkari's study specifically stated AVA has no known signal for hepatotoxicity.
No liver signal. That's a big deal.
It's a critical differentiator. And Tian's study from China provided real-world backup for this. They saw no cases of liver toxicity blamed on AVA, even in patients who already had liver dysfunction.
Even with pre-existing liver problems?
Yes. They even had one patient with liver lesions and marrow fibrosis from prior Avatrombopag use, whose condition didn't worsen on AVA.
So AVA looks like a safer option for patients with liver concerns, like CLD.
It certainly appears to be a preferred option in those cases, removes a major worry, opens up treatment for a vulnerable group.
That's excellent news. What about other side effects? Anything else pop up frequently?
Other things were reported, but generally less common and milder. Headache came up about 3% in one pediatric study, mentioned in the ITER cases, and seen in Wang's pediatric cohort too, usually resolving with dose changes.
Okay, headaches. Anything else?
Easy bruising in one case. Wang's pediatric list also included GI stuff like nausea, fatigue, fever, nosebleeds, muscle pain, myodynia, rash, dizziness. Kind of a range of usually mild things.
Standard stuff you might see with various meds.
Pretty much. But importantly, especially for the long term in kids, Wang reported no serious AEs like myelofibrosis or cataracts during their follow-up.
No myelofibrosis or cataracts is reassuring for chronic use.
Very reassuring, particularly in a pediatric population potentially facing years of treatment.
Okay, so we have this profile of generally mild, manageable AEs, with thrombocytosis being the main one to watch. Did these side effects actually cause many patients to stop taking AVA permanently?
That's a key practical question, and the answer, based on the large Spanish cohort, is not very often. Only 8 out of 268 patients, just 3% permanently stopped AVA due to thrombocytosis, and only 7 others stopped due to other AEs.
So very few discontinuations purely due to side effects.
Very few. In fact, stopping because the drug simply wasn't working, lack of response was much more common, happening in about 14% of patients.
Interesting. So if patients stop AVA, it's more likely due to lack of efficacy than intolerance.
That's what this data strongly suggests. It speaks volumes about its overall real-world tolerability. People generally stick with it if it's working.
Okay, that's very practical insight. Let's shift fully into the practical side now. How is AVA actually used in the clinic day to day? What about dosing? Is it just a standard dose or more personalized?
The real-world data definitely points towards a personalized, tailored approach, not a rigid, fixed dose.
Flexible dosing.
Very flexible. Clinicians are clearly adjusting doses based on how individual patients respond, watching those platelet count fluctuations. This came through in Galamaga, Ito, Pascual-Izquierdo, across the board, really. They're actively managing the dose.
Adapting to the patient.
Exactly, though we did see some examples of typical starting doses, especially in kids. Liu and Wang reported starting kids aged 1 to 6 on 10 mg a day and those 6-18 on 20 mg a day.
Providing a practical starting point.
Right, a place to begin, then fine-tune based on response. It's a dynamic process.
And we touched on convenience earlier. Can you elaborate on those practical advantages again? The oral dosing, lack of food restrictions. How much does that matter in practice?
It matters hugely. That oral administration without strict dietary rules is a massive practical plus. Unlike Avatrombopag, where you have to worry about timing around meals, avoiding calcium, etc., AVA can just be taken with food.
Simple.
Much simpler. Kari, Tian, Wang, they all highlighted how this boosts convenience and, you'd expect, patient compliance. Less hassle, easier to remember, easier to stick with long term.
Less disruption to daily life.
Absolutely. And then there's the comparison to injections. For patients switching from romiplastim, getting rid of weekly subcutaneous injections is a big deal.
Especially for older patients or those with needle issues.
Exactly. Ito's cases and Kari emphasize this. Avoiding injections significantly improved patient preference and their experience of treatment. These aren't small details. They're critical for making chronic treatment sustainable and improving quality of life.
Convenience clearly drives adherence and patient satisfaction. But let's talk about the elephant in the room, cost and logistics. How does AVA fit into the economic picture, especially compared to alternatives like platelet transfusions?
Cost is definitely a major real-world hurdle. Tian's study from China was very blunt about this. AVA was the most expensive TPO-RA there.
Most expensive. Did that limit its use?
Significantly. They reported that unaffordability was the reason 27% of patients in their study had to stop taking AVA.
Well, over a quarter stopped, purely because of cost.
Yeah, it's a stark reminder of how economic barriers impact access, even when a drug is clinically effective. Forces really tough choices.
A major challenge. But how does it stack up logistically or maybe even cost-wise against something like repeated platelet transfusions?
That's where the picture gets more complex. Galamaga's study pointed out that by stimulating the body's own platelet production, AVA avoids the whole logistical complexity of transfusion.
Infrastructure needed for transfusions, right?
Exactly. Sourcing blood products, storage, cross-matching, infusion time, monitoring for reactions, it's resource-intensive. While AVA's direct drug cost might be high, avoiding repeated transfusions has its own value.
Fewer resources used, potentially lower risk of transfusion reactions or infections.
Right. So it's a trade-off. High upfront drug cost versus the ongoing costs, risks, and logistical burden of managing severe thrombocytopenia with transfusions. AVA potentially reduces the need for those more invasive, complex interventions.
A complex value equation.
Yeah.
Okay, we've covered a lot of ground. But real-world evidence isn't perfect. We need to talk about the limitations of these studies and any gaps in our knowledge.
Absolutely crucial to acknowledge the limitations. Most of these studies were retrospective observational design.
Meaning no randomization, no control groups.
Exactly, which means they're prone to biases. Selection bias, for example, maybe certain types of patients were more likely to get AVA. This was noted as a limitation in Kari, Pascual Izquierdo, Tian, Wang. We see strong associations, compelling outcomes, but proving direct cause and effect is harder than in an RCT.
Makes sense. What other limitations?
Sample size varies. Some cohorts were large, but others, like Galamaga with 6 patients or Ito's case reports, are very small, limiting how much you can generalize from them.
Small n's are tricky.
They are. Also, variability across studies. Liu's meta-analysis pointed out differences in how studies defined response, how they adjusted doses, even how they defined AEs. This heterogeneity makes direct comparisons tricky. Lack of standardized dosing and treatment duration also complicates things.
Apples and oranges sometimes.
A bit. And finally, relying on spontaneous AE reporting systems like FAERS has known biases underreporting, reporting influenced by when a drug hit the market. Important caveats to keep in mind.
Definitely important context. So given these limitations, are there specific patient groups or conditions where we still need more real-world data on AVA?
Yes, for sure. While we learned a lot, especially about ITP, some areas could use more data. Chemotherapy-induced thrombocytopenia, CIT, for example. We had that one case series, but larger observational studies looking across different cancer types, different chemo regimens would be really valuable.
Understand its role more broadly in oncology.
Exactly. And pediatric ITP, while we had some good data, more long-term real-world follow-up is always welcome in kids. Plus, data on less common indications or specific subgroups within ITP or CLD would help fill out the picture. Always more to learn.
So that leads to the question, what's next? What are the key unanswered questions or research priorities for AVA?
Several things come to mind. First, long-term safety. The current data is good, but we always need more information on very rare AEs or the effects of use over many, many years. Continued registry monitoring is key.
Long-term vigilance.
Right. Second, we still need more direct head-to-head randomized trials comparing AVA specifically against Avatrombopag or romiplostim for key outcomes in different patient groups. Real-world data suggests differences, but RCTs provide stronger evidence. Liu and others highlighted this need.
Definitive comparative data.
Third, understanding why some patients become refractory to one TPO-RA but respond to another. Beyond just knowing they have different structures, what are the mechanisms? Ito touched on this. Deeper understanding could lead to better personalized strategies.
Predicting responders.
Potentially. And finally, given the cost issues, more real-world economic analyses. Cost-effectiveness studies are crucial for guiding decisions, informing policy, and ensuring equitable access.
Okay, that makes sense. So let's try to synthesize all of this.
Yeah.
After this deep dive into the real-world evidence, what are the absolute key takeaways about Avatrombopag that our listeners should remember?
All right, the big picture takeaways. First, consistency. Across these varied studies, AVA consistently showed it's effective at raising platelet counts and doing it safely and, importantly, quickly.
Effective, safe, and fast.
Yes. Second, real clinical impact. Its use frequently reduced the need for platelet transfusions and also helped avoid chemotherapy holds or dose reductions, major benefits in practice.
Reducing interventions, keeping treatment on track.
Exactly. Third, a huge quality of life benefit. A significant number of patients could reduce or completely stop other ITP medications, especially those chronic corticosteroids. Less polypharmacy, fewer steroid side effects.
Steroid-sparing effect is huge.
Huge. And fourth, safety profile. Generally well tolerated. Thrombocytosis was the main AE, but typically manageable with dose adjustments. Serious AEs were rare, and compared to other TPO-RAs, AVA seems to have a favorable profile, especially regarding liver toxicity and maybe overall AE burden based on FAERS data.
Sort of robust profile in real-world use.
That's the picture that emerges from these studies, consistent utility and a manageable profile in practice.
Okay, so based on all that, where does AVA really offer the most value? In which specific clinical scenarios should clinicians be thinking about it?
Several scenarios really stand out. First, clearly, in patients who are refractory to or intolerant of other TPO-RAs like Avatrombopag or romiplostim, the evidence strongly supports switching to AVA in these cases.
The Swiss strategy.
Yes, leveraging its distinct profile. Second, patients needing a rapid platelet increase before a procedure. Its fast onset is a major advantage there.
Pre-procedure boost.
Third, patients with chronic liver disease or other liver issues. That lack of a hepatotoxicity signal makes it a preferred, safer choice for them.
The liver-sparing aspect.
Definitely. Fourth, thinking about the patient experience. Those who value convenience, have compliance challenges, or simply prefer an oral pill without dietary restrictions, especially relevant for some elderly patients.
Patient preference and adherence.
Crucial factors. And finally, as we saw in the case series, its utility in chemotherapy-induced thrombocytopenia, helping patients stay on their vital cancer treatment without interruptions.
Keeping chemo on schedule. Very important.
Paramount in oncology.
It's really clear how this real-world evidence adds so much practical context to the clinical trial data. It shows AVA is a valuable tool making a real difference. But, as always, the learning continues. What's the final call regarding future data?
The final call has to be for continued vigilance and data collection. We absolutely need ongoing prospective registries and continued real-world monitoring.
Keep tracking outcomes.
Yes. It's not just about confirming what we've seen, but refining our understanding of long-term safety, long-term effectiveness, how it performs in even broader populations, those underrepresented subgroups, identifying any very rare long-term effects. That systematic collection helps us continually optimize treatment and ensure the best, safest care.
Always striving to improve patient care through ongoing research.
Precisely. And perhaps that leaves us with a final thought to consider.
Okay, leave us with something to chew on.
While considering how differently patients can respond to various TPO-RAs and how much patient convenience impacts long-term adherence, how can we as clinicians get better at personalizing TPO-RA selection? Moving beyond just aiming for a platelet number to truly optimize for both efficacy and quality of life, considering each patient's unique situation and journey. How do we best tailor these powerful tools to help patients live their fullest lives?